So hello everyone. Welcome to the Pain Science lecture event and Win Back to Car Open House. So thank you everyone who's joining us virtually as well. I wanted to just start with saying that we decided to run this event because September is Pain Awareness Month. And there is a lot of multidisciplinary care that goes into treating individuals who experience pain. We will be speaking specifically about persistent or chronic pain. And I want to encourage everyone when we get to the Q&A section, if you have questions or anything, feel free to ask. We want this to be an open opportunity for people just to chime in and ask questions. We have specialists here. Dr. Sieferman is joining us here in office. And we have Dr. George Sherian, who will be joining us later for the Q&A section as well. He is joining us virtually. So without further ado, we're going to get into the PowerPoint presentation first. I just ask anyone who is joining us virtually, please keep yourself muted while we are doing this PowerPoint presentation, but when it comes time for the Q&A, you can unmute yourself if you have questions. Okay, so pain science. I will be speaking and discussing pain science under the understanding of the biopsychosocial model. For physical therapy, we study pain science in this way, and this is how we conceptualize pain and how we format and structure treatment for patients. And also, for anyone who is joining us and who does not know me, I should introduce myself. My name is Dr. Melanie Carminati. I'm the owner of Inspira Physical Therapy and Pilates here in Park Slope, Brooklyn. And we treat a wide array of diagnoses, but a large portion of what we see is chronic or persistent pain, or people who experience chronic and persistent pain, as well as pelvic floor diagnoses. As a disclaimer, this is an informal introductory presentation. This does not certify anyone or license anyone as a healthcare provider. And I want you to use this information within your scope of practice, or just know whatever your scope of practice is. I want to disclose that I have worked as an ambassador for Win Back to CAR, but related to this event, there are no financial relationships. So I have a few goals for this presentation, for this event, and I want to just acknowledge first that individuals who experience persistent and chronic pain, it's a very challenging thing to be going through, and it takes many providers to support the care for someone who has persistent pain. So my first goal is to provide a better understanding of the science behind the painful experience for individuals with persistent chronic pain, then to provide some treatment options for through multidisciplinary care, and then finish up with the Q&A with expert physicians and an opportunity for patients to have an open conversation. So the agenda, we're going to talk about what is pain first, then the biopsychosocial model. We'll speak about some pain terminology, the sensory homunculus, which is a fun word, neuroplasticity, some common pain diagnoses. We'll speak about physical therapy treatment options. I'll briefly touch on the multidisciplinary care for people with pain. We'll have a Win Back to CAR demonstration, and then we'll also have some time to go over the dyspareunia case that Dr. Milo Lohanda and I put together for the use of Win Back to CAR for someone with pelvic pain. So what is pain? So this large paragraph here is from Lorimer Moseley. We reference explain pain a lot in this office, and I want to just read this first part because it's very important and it gives you the understanding for what I'm going to talk about for the rest of the presentation. So pain depends upon the brain evaluating a massive amount of information, including danger data from the danger detection system, but also cognitive data, for example, expectations, previous exposure, cultural and social norms, and beliefs. We know now that pain can be turned on or turned up by anything at all that provides the brain with credible evidence that the body is in danger and needs protecting. It's important to remember that this pain message is a danger message. Remember that it is not a pain message that is being modified, but a danger message. So we're going to go into next the whole understanding of neuroplasticity, because this is what impacts persistent pain, and this is why it takes a team to treat someone who is experiencing chronic pain. So, as that paragraph explained, pain relies on context. There's sensory information that needs to be evaluated by your nervous system, so via smell, touch, sound, taste, sight. And the evaluation of this information involves complex memory, reasoning, and emotional processes, consideration of potential consequences of the response. And this is where the biopsychosocial model comes in. So, this is a pain science model for treating all pain. So, there is biological, mechanical considerations, psychological, and sociological. All of these things are interconnected and depend on one another in creating the painful experience. So there are different biological influencers of pain. This can be visceral, different organs are listed there, vascular, neurogenic, or musculoskeletal. There are different psychological and sociological influencers for the painful experience. For psychological, this could be stress, depression, anxiety, different traumas that you've experienced. Sociological could be the lack of support system, lack of resources in your environment, or family history of persistent pain. Now, some of these terms here are important for the understanding, and the first one is nociceptors. Nociceptors are, if we use the analogy of your body being a house, nociceptors are like the fire alarm or the smoke detector. So they're picking up on that information and they're setting off that alarm to let you know that there's potential danger, and that's when you experience the pain. Central sensitization is when there are changes in your brain, in the central nervous system, and this creates a sense of increased sensitivity to the pain, or hyperalgesia, which is another term when it comes to pain. So this sensory homunculus, I mentioned that already. This is a convergence of nerve endings that creates a topographical map in the brain of your entire body, and it's located in the postcentral gyrus. The more sensitive the region of the body, the larger its representation in the brain. So for a normal distribution, there's large amounts of nerve endings in your hands, your feet, and your lips. So what you're going to see next is an image that represents what is in our brain, or what the sensory homunculus is and what that map looks like in our brain. Right, this is a sensory homunculus, kind of funny looking, but you can see how the hands are super large, the lips, the tongue, and that just has to, that represents the nerve endings and that distribution and the amount of them being there. This is important. We need to have a lot of sensation in our hands and our mouth and our tongue for survival and for dexterity and all the things that you use your hands and mouth for. This is another image that shows the sensory homunculus. Sensory homunculus, if you are, it's on the left-hand side of the screen, and you can see also how the body is distributed and how that topographical map is laid out. I'm not going to spend too much time talking about phantom limb pain, but this is something else when we are considering pain science and the topographical map with the sensory homunculus that you're considering in your understanding for how you're going to be treating the individual. So neuroplasticity, the brain has the ability to change pathways and rewire brain signals. Your homunculus is always changing, and we can influence the change through utilizing the biopsychosocial model for pain treatment. You have to address all of those factors, biological, psychological, and sociological, when you are treating someone who is experiencing pain. So thoughts and beliefs are nerve impulses. Your brain does have the final call for deciding if something is dangerous for the body tissue. Thought viruses. So these are common in people who don't necessarily have an understanding of what the pain or danger signal is and what it's telling them. An example could be, I'm in pain, so there must be something harmful happening to my body. But what we try to encourage our patients in this office and all providers who are informed is to challenge the thoughts. And if you are experiencing a painful sensation, to remind yourself, obviously, if you have sought out care and you're not being attacked and it's not an acute situation, we're talking about persistent chronic pain. If you're undergoing treatment many times, what we will talk about is to challenge the thoughts and to remind yourself I'm not in danger, and shift your thinking into finding the safety in you, or the SIMS. DIMS and SIMS is another terminology that we use in pain science understanding for physical therapy. And we encourage patients to find that, but physical therapists can only coach. We refer tremendously to pain psychologists who can help and use specific techniques to challenge thought patterns. And this is just a map or an image of the DIMS and SIMS. It gives some examples, talks about things you hear, you see, things you do, things you say, places you go, and how that would shift depending on your thought patterns. So key pain science points here: how you think about your pain can change the way it feels. Understanding pain is important because it changes the way you respond to pain. Retraining the pain system may mean testing yourself physically, moving more than you normally would, and being honest about your current attitude and beliefs. It takes a team, and I'm going to get into that in the upcoming slides, but it's important to know as a provider that our word choice does impact the patient's experience. So we talk about neurolinguistic psychology in this office, but also in Pulsar Pilates training, because that influences your movement experience as well. Okay, so next, physical therapy treatments. So again, this presentation and everything we're talking about today is just an overview. We're not going to be going in depth into anything regarding pain science, but I wanted to just give a general understanding. We're going to now talk about some physical therapy treatments for persistent chronic pain. So after someone has come in for an evaluation, or when they come in for the evaluation, whether they were referred by one of the providers or they found us on their own, we would look at them holistically. We would assess them from head to toe, consider all musculoskeletal considerations. And then for treatments, we might do different manual therapy treatments, such as craniosacral therapy, which is a form of osteopathic manual therapy. And this is tremendous for patients who have an upregulated nervous system after long periods of pain. If they've been experiencing pain for a long time, their nervous system is often upregulated, and through craniosacral therapy, we can help to get them back to a healthier baseline so that they can progress in their physical therapy. We also do visceral manipulation, which is another osteopathic technique. We do myofascial release, kinesiotaping, Graston, and different modalities such as wind back to car, which I will be talking about soon. For therapeutic exercise and neuromuscular reeducation, this varies depending on the diagnosis, but we use many mindfulness-based movement methods such as Pilates-based exercises, but different strengthening, stretching, and stabilization comes into play as well. So again, I am a doctor of physical therapy, so I am not a psychologist, but I am just listing this here because this is what we often refer patients who are coming in and might have chronic pain. Different techniques that could be used could be CBT, or cognitive behavioral therapy, ACT, acceptance commitment therapy, and other psychotherapy methods that facilitate mindful shifts in thought patterns. This is necessary in order to promote that positive neuroplastic change for management of a painful experience and correction of central sensitization. At the International Pelvic Pain Society conference last year, they presented a outcome measure or questionnaire called the Central Sensitization Inventory, and they advised us as physical therapists to utilize that in patients who are having persistent chronic pain, and to use the results of that as a referral for CBT, because that's what they have researched has shown to be very effective in helping patients who have central sensitization as a result of chronic pain. With psychology, with a licensed psychologist, you can address other psychological and sociological factors that might be influencing your painful experience. Hypnosis is another technique that some psychologists use, although there are other clinical hypnotists as well. I'm mentioning gastroenterology because many of our patients come in here with multiple systems involved, and there is a known and researched brain-gut connection. Our microbiome does impact our mood, so it's an important consideration for mood, especially if there are other gastrointestinal symptoms that are happening. physiatry. I'm not going to spend too much time talking about this because we are blessed to have a physiatrist in the house with us tonight. But this is a medical specialty that offers conservative, non-surgical treatments to address impairments in function, and specifically for those with pain. Dr. Sieferman will get into that much more later, but some of the treatments can include trigger point injections, dry needling, PRP, prolotherapy, nerve blocks, Botox, and much, much more. Pain management, this is complex, especially for someone who has persistent chronic pain. It's important to have someone who is helping you manage your medications, especially because those patients sometimes may be on multiple medications. So I want to just mention that as well. And then other practitioners, osteopathy, acupuncturist, massage therapy, registered dietitian, somatic movement practitioners are very important as well in facilitating that rehabilitative process and a positive movement experience for those who have persistent chronic pain. Okay, so now I'm going to talk about wind back to car therapy. So I was first introduced to wind back to car therapy almost 2 years ago, and it was because I was searching for a modality that I could use for patients with musculoskeletal orthopedic conditions, but also for pelvic floor. And the beauty of wind back to car therapy is that they have many different electrodes or applicators that allow you to work externally, but also internally. So as a physical therapist, we could wear a bracelet on our forearm while we're doing the internal manual therapy. And for our patients who have pelvic pain, which I will touch on when we talk about the case study, because this is what we did with that patient, we are able to transmit the radio frequency current through our hands into the patient and feel the tissue changes as we are doing the manual therapy. Feels like a warming sensation for the patient, so it actually feels good, and it promotes long-lasting results. Before you change that, so we do have Kevin Sheehan here. So if anyone has questions about wind back to car therapy and the science of that, he's the guy, because he talks about that all day. But I'm going to move to the next slide now, actually. So I'm going to leave this to Kevin to maybe take us through this slide.
Yeah, so what this slide is outlining is really just the principles behind wind back and why there are multiple frequencies. So various tissues in the body respond to different frequencies. So this chart here is just showing, as we work in from a high frequency of 1,000 kilohertz to a lower frequency of 300, the permeability of the cellular structure changes in that range. So at 300, we're affecting deeper tissues in the body, such as bones, tendons, and joints. And with that higher frequency, we're treating more superficial pathways, such as your dermis, epidermis, and fascia.
Great. Thank you, Kevin. So Ohm's law comes into effect here. The higher the resistance, the greater the heat, the higher the intensity, the greater the heat. And we feel this as a provider when we're using wind back to car therapy, because we can feel when we get into an area where there's a lot of fibrotic or just adherent tissue, we feel the heat increase. And so as a patient, you would feel the heat increase as well, but it gives us really amazing feedback while we're doing the manual therapy with the device. Cellular metabolism. Kevin, do you want to talk about this as well?
Yeah, so the crux of what wind back is doing is kind of twofold. The benefit, first and foremost, to the patient is obviously going to be managing that pain. So I think in a couple slides it'll get into that. But what it's also doing to create a sustained change in the body and help you manage your pain long term is what it's doing at the cellular level. So coming back to what I just talked about with the permeability of the cell, we're essentially kind of trying to open up that cell wall, get all the toxins out of it while getting nutrients and protein into the cell, which is going to accelerate the body's natural healing process. So everything that tech art therapy is doing is very natural to the body. And that's kind of the benefit of that is, we're helping the body heal itself. We're not applying something to the body that's foreign to it.
Okay, and I think Kevin already mentioned the diathermic effect. Yes, yep, okay. Let's move on to the next slide. So there are different uses of wind-back-to-car therapy. We've mainly been speaking about pain, but I want to mention some others. Tissue healing, obviously, but connective tissue repair. We use wind-back-to-car therapy with patients who have diastasis recti abdominis, and we see a lot of benefit with that as well, with the mixed electrode. And then we also use that setting for patients who have EDS or are somewhere on the HSD spectrum, and it helps, and we see the changes in whatever joint and connective tissue that we're working on in that area improve. We can use it for lymphatic purposes, and then we were just speaking before this presentation about RET+, which is used for muscle reeducation, which we also do use for individuals who have EDS, because there is the need to sometimes underactive muscles in the areas where there is hypermobility. That external electrical current helps to facilitate the muscle contraction and retraining in a more effective way for rehab. So there's many common pain diagnoses, but I'm just listing a few here. Back pain, neck pain, pelvic pain, hip pain, everything listed there. I also just mentioned EDS and HSD. We'll be getting into that more in the Q&A. Okay, and then the last thing I want to speak about before a quick demo of wind-back-to-car therapy is this case study that Dr. Mila Lahanda and I put together. We had a patient who had pelvic pain. She had superficial primary dyspareunia, which means painful sex. She would have pain upon initial penetration. And so we used the wind-back-to-car therapy after, I think it was a few sessions without the wind-back-to-car therapy, and we saw tremendous improvement over 7 sessions, and the patient reported significantly decreased pain. It was almost completely gone. I think we continued a few sessions after that. But as mentioned before, the wind-back-to-car therapy, when we use it for pelvic floor physical therapy internally, it's a bracelet that we're wearing, and the current is transmitted through our hands into the patient, and it promotes longer lasting changes in the tissue, especially for individuals who are tight or hypertonic in their pelvic floor, and that is the source of their pain. We can feel that at start before we get into treatment. Many times the quality of the muscle is changed, and with the wind-back-to-car therapy, it helps to promote that normal integrity in the muscle itself. So significant improvements were found after initiation of the use of wind-back-to-car therapy during the internal manual therapy portion of pelvic floor PT. After the 6th visit, the patient reported being happy with the results. So Mila and I use this. Mila, Kylie, and I use wind-back-to-car therapy a lot with our patients, especially if there's hypertonicity in the pelvic floor. And this case study just strongly supports the use of it for specifically for the treatment of superficial primary dyspareunia. Okay, and now time for a demonstration. So I'll want to demonstrate on Mila. So Mila does a lot of manual therapy in the office. And so we're going to treat her wrist extensors. We're going to use a grounding plate for her to put her hand on. There are different electrodes. I'm going to use the capacitive with her. This is more superficial in terms of the depth and the tissue that we're going to address. All right, so we're going to put some lotion on. You're right-handed, Mila, yeah? I can feel she needs this. She does a lot of manual therapy. She's pretty tight in there. I'm just going to keep this. Okay. So we're doing capacitative, which is more superficial, as I said. I'm going to start at 20%. Why don't you put your Mila? Yeah. So I'm starting at a low intensity, and then I'm going to bump it up. Do you feel the ready or no? A bit higher. So this is an example of she's starting to feeling a little warm. So this is an example of external use. I'll show you the bracelet as well. As a good. No, a little bit higher, you think? Just a little more time. So it's been about 1 minute now. And then as the provider, I feel some warmth actually. No, I do. Okay. Just she wants more heat. What'd you say? Feels really good. Nice warm sensation. I can feel some of the tissue changes happening too. Starting to loosen up. So as a manual therapist, you can still feel through the electrode too. So I feel you feel it loosening right now, right? Okay, so this would be an example. We would do this for a few minutes. So depending on what she's coming in for, I'm just going to pause now. That would impact which electrode we would use, and it would impact which electrodes we would use after. Say if she was having some kind of tendinopathy, we would then go into possibly a mixed setting or maybe a slightly different setting for the CET, like we were talking about with Kevin. We could even use some of the deeper RET resistive to get deeper into the tissue. So this was just a demo, but it is extremely effective and it helps a lot. How do you feel so far? You feel more. You want more? I want to do the mixed on you just for a minute so you can feel the difference. So the thing with the mix is that we won't need the grounding plate because the mix actually has all three in one. So there's 3 little knobs on there. And so this is the one that we use a lot with patients who have connective tissue things going on. We use it in different regions, maybe around their wrist, maybe around the elbow, definitely around the foot and ankle. Again, we mentioned it for people who have diastasis recti abdominis. It's helpful also. And it's a different sensation because you have the 3 electrodes on the end of this one device. Yeah. It takes a minute or 2 to warm up. And so this is the most ergonomic setup right now. Normally would be on a high-low table and doing a treatment there. Okay, so that was a little demo for you. There's multiple sensors or multiple electrodes, and then I just want to briefly show the bracelet too, because it does look just like a bracelet. So when we're doing the internal pelvic floor work, we wear a bracelet here with a gloved hand and lubricant, and we do the same internal work that we would do without the Takar therapy, but with it helps with the longevity of the results. Now we are going to go into our Q&A. So I'm going to invite Dr. Jason Sieferman up. Thanks so much for coming.
Thanks for having us.
As I mentioned, Dr. Sieferman is a physiatrist. He is the owner and founder of Manhattan Pain Medicine, and he has a tremendous amount of knowledge in regards to treating patients with chronic and persistent pain. So we were very blessed to have him here. So I wanted to just have you take us through a typical initial consult for your patients and tell us what they can expect.
Sure. So our first visit is usually about an hour long, often longer. It depends on how much we have to go through to get to know you, enough that we can make some decisions together about next steps in your care. So, come to the office, check in, paperwork, normal stuff, and then we'll start talking. I basically want to understand the how and why of everything. Mm-hmm. And just like with other problem-solving approaches, you ask the 5 whys to get to the bottom of an issue. We do the same with pain. Mm-hmm. So, if you're having pelvic floor dysfunction, why? How did this come to happen? Mm-hmm. You have pedal neuralgia. You have pedal neuralgia. Right. you have endometriosis, that's kind of an endpoint, right? There are other things we'll sort of dig into as far as we can. It's easier with mechanical pain. If there's a hip labral tear, for example, how did you come to have a labral tear? Was there a stress and injury? Was there an impingement where the bone sort of repetitively irritated labrum? Was it a singular incident? Is this repetitive? Sort of getting to understand the how and why and how it came to happen, because whatever treatment path we go down, if we don't get to the core issue of how it started, it's going to happen again. A good example is an epidural for low back pain. So epidurals are great at washing disc material off of nerve and calming nerves down, but if we don't understand why that disc herniated in the first place, if we don't stop that process, it's going to reoccur.
Right, so getting to the root of the problem
as much as possible.
And can you talk about the different treatments that you utilize in your office?
This will be a long conversation. So we think of treatments in different buckets. So first bucket would be medication. And medications can serve a few different purposes. If there's an inflammatory condition, if you have lupus or rheumatoid arthritis, you most likely will significantly benefit from some immune modulating therapy, which our rheumatologist would offer you.
Right.
And without that, your life is likely going to be shorter. So there's a substantial shift in outcome because of that medication. Other situations, mostly with pain where there's not a cause that the medications can cure, the medications are more palliative. So say you do have a disc herniation and it's hurting, sure. Muscle relaxers, anti-inflammatories, they'll make it feel better in the moment, but it's not really fixing the underlying issue. So medications do have a role for temporizing pain and helping you tolerate the things you need to do to treat the root cause. So, for example, they're coming to you for physical therapy, but they're sore afterwards and they can't tolerate that. Or they're hurting too much to engage in physical therapy, and so they're a little afraid. Then we will use medications to help facilitate that. But it's not necessarily meant to be a long-standing end-all treatment. Next bucket is physical modalities. And this is where physical therapy comes in, sometimes chiropractic or acupuncture, any other physical manual sort of approaches to address the mechanics of the body. In this bucket, we then subdivide into more active therapies and passive therapies. Active therapies are when they're actually doing exercise, training their body, stimulating the neuroplasticity that you talked about. Passive are when they're receiving therapy. So more massage, acupuncture, chiropractic is more passive. We know that active therapies tend to have longer term benefit. And it's really what we're trying to achieve is changing how they use their body. So when we're prescribing a physical therapy, it's usually because we've identified a mechanical issue that's leading to this pain. We want to stop this mechanical issue. So train them up.
Right.
Next bucket would be injections.
Okay.
And we can inject many things into many places for many different reasons. It's the most common thing that we do is a steroid injection or a cortisone injection. Yes, we can do this, but this is your grandparents' doctor, right? We want to understand how and why something is happening. If you're having a gout flare, yes, a steroid in that joint is the best, most immediate treatment for you. But if you have a hip labral tear and it's recurrent and repetitive and it's not getting better, steroid is not going to do anything for that. We want to try and understand how it came to happen. If it's in the setting of hypermobility, if you sprained your hip, if there's a labral tear around the hip because of hypermobility, we want to try and strengthen the supporting structures. So we might use regenerative medicine, prolotherapy, platelet-rich plasma to strengthen those ligaments to make your hip more stable so that labrum can fall down. So trying to understand how, what, where, why. Things like Botox we use to calm down the nervous system. Sympathetic blocks we use to reset the sympathetic nervous system. Whole variety of options there. Final bucket, pain psychology. Pain is a journey. I should say chronic pain is a journey. If you stub your toe, that's not a long journey, short journey. But if you're going through a process of discovering what's going on with your body, how and why it came to happen, why it's not getting better, because with any injury, we expect things to heal and to get better. And if they don't, it's a struggle to understand why. And there's a lot of guilt and anger and resentment and a lot of processing that goes along with that. And then let's take an extreme example. Let's say you're in an auto accident, but your best friend who was driving was in that same auto accident and they passed away. And you just have back pain. So horrendous situation. And these situations happen all the time, very unfortunately. But there's survivor guilt along with that. There's an intrinsic link between that emotional association with the pain you're experiencing. Untangling these things can be very difficult. And then say you're out of work for a while. How do you reflect on yourself as a person? Who are you as a person? How does that affect your self-image? And then if things aren't getting better and you don't think you can return to work, that adds layers onto this that just increase anxiety and increase stress. And it's challenging to go through all this. So the role of pain psychology is really to help you sort of categorize your feelings and understand the linkage between your feelings, and also simultaneously approach your care treatment plan and help you organize and strategize and make decisions, because so much of this, it's so overwhelming. It's really difficult to think through things granularly and make good decisions for yourself. It can be very difficult. Switching to a different scenario. Anytime there's visceral pain, so endometriosis, Crohn's, ulcerative colitis, any of these sort of internal organs, the pain from these organs go through the sympathetic nervous system. That's that fight or flight response. And when we make decisions, there's two parts of making a decision. There's the intellectual component, which is taking all the data points that you think or know to be true. And then there's the emotional part of it. And if something doesn't feel right, no matter how much we know about it, it's really hard to pull the trigger on that decision. The problem is that whole feeling right bit, trusting your gut, it's not just a metaphor. There's literal feedback that you get from your gut that tells your brain how your body is feeling. And if something doesn't sit right, if it doesn't feel right, you can't rest in that decision. And unfortunately, when the autonomic nervous system is disrupted, which can happen with POTS, with Ehlers-Danlos or mobility syndrome disorders, or with endometriosis or any other GI type pain, it can be really difficult to make sense, make decisions, make choices for yourself. So the role of pain psychologist there is really to help you reflect, process, keep track of notes, and so you can use this information to try and make the best decisions for yourself going forward.
Thank you for that. I think one of the many things you said were important there, but the grieving process in for individuals who have chronic pain in regards to their identity and their abilities in the world is something. I just wanted to mention that it's normal to experience grief, and this is why pain psychology is so important, because
there are layers to this journey.
It's multi-layered, yes.
And even for patients, when they start to get to the other side of it, when they figured out what's wrong and how to fix it, and we start working through it, and they're seeing the light at the end of the tunnel, there's this whole new kind of anxiety that comes in. It's like, oh my God, what did I just go through? What is this? Like there's a redefining of the self that occurs in that moment, and sometimes that anxiety just descends so unexpectedly. And just knowing that every step of this process, there's a role for someone who's skilled at guiding you through it is important to know.
I wanted to have you speak just about headaches, because I know that there are some special treatments that you provide for people with headaches.
So,
and migraines?
Yes. So headaches, like everything else, we want to try and understand what exactly is going on. And there are several different subtypes of headaches. So if someone is a migraine, or migraines are a genetic condition, and we have diagnostic criteria for migraines, so we know if you're getting a throbbing, pulsating pain, usually on one side of the head, usually light sensitivity, sound sensitivity, nausea, things like that, typically classified as a migraine. And these are genetic. And there's a lot of different genes that go along with migraine, but generally you'll have a relative or a couple of relatives who also get migraines. Knowing if you get migraines is important, because many people with other kinds of headache will also get migraine, and the migraine can be triggered by the other kind of headache. So if migraine is present, one of our first goals is to treat and suppress the migraine, get the migraine under control, and then focus on what's left. Migraine is very much involved with the sympathetic nervous system, so it ties into everything else we were talking about with the sympathetic nervous system. So just identifying that and treating it is super important. So to treat migraine, if you're in a migraine in the moment, we can do IV medications, we can do scalp blocks. There are some short-acting medications. There's a new nasal spray out that works within 7 minutes that we can use to block a migraine. There are then suppressive therapies that we have to keep the brain calm, and many medications that have been around for decades, like propranolol, topiramate, amitriptyline, They're really good at suppressing migraine, just so it stays under control. If you can't tolerate those, Botox is phenomenal. It's one of my favorites. And then there are newer infusions like Vyepti, or the once-a-month injectables, Mobic and Emgality Ajovy, which blocks CGRP, which also helps keep the migraine process calmed down.
Okay.
If it's not migraine, if there's other kinds of headache, that's when we dig into what else is going on.
Right.
And this can be craniocervical instability. So people with hypermobility spectrum disorder or Ehlers-Danlos will often have inadequate support between the head and the top of the spine. And the skull and the brain, it all weighs 20, 25 pounds. And the neck is quite small. So you can imagine it's almost just bobbling there if there's inadequate support. And the vagus nerve comes out, the sympathetic chain goes up, there are blood vessels that come out. If there's any stress to any of these structures, it will stimulate some kind of symptomatic response, and it will often trigger a headache. And these headaches are different than migraine usually. Usually there's more positional intolerance. People can't stay upright for so long. They can't stay focused. They'll usually have a convergence disorder, which means when they try to focus their eyes on something, they might be able to do it for a little time, but then it starts to go double. And it's nothing against blurry. It's just they can't focus. It's double vision. So they'll typically lay down, take the stress off the craniocervical junction, things will calm down, they'll feel better, then they get up and do this again. This is different than a high-low pressure headache, which will be worse if you're upright, unless it's, this is where things get tricky, because if it's a high-pressure headache, you'll actually be better upright, worse laying down. But if it's low-pressure headache, you'll be worse upright, better laying down. But distinguishing that from craniocervical instability can also be tricky. And it can also be tricky because people with Ehlers-Danlos are predisposed to spontaneous epidural leaks, which can also, we're getting off on the tangent. Many other kinds of headaches we can help.
But since this has already come up, why don't we transition into EDS and hypermobility?
Yes.
So how do you, what's your approach for someone who comes in presenting with EDS, say they haven't been diagnosed yet?
Yeah, so the first step is really recognizing, is there some hypermobility present, and to what degree is it playing or interacting with their main complaint? I feel like most patients that have it don't realize that they have it.
Right.
It's usually a novelty to them. And sometimes we'll ask, do you have flat feet? And everyone says, no, I don't have flat feet. But of course, many of us do. Many of us do. So sort of just looking around, taking a look at how people hold their bodies, how they use their bodies, it really gives you a clue, because you'll see a constellation, which is really the compounded effect of gravity over time. Because the enemy of hypermobility is gravity. And this is where Melanie's therapies with Pilates especially is essential, because learning to activate all the core stabilizing muscles, recognizing that proprioception is affected. So proprioception means your sense of your body's position in space, because when the ligaments are extra stretchy, that proprioceptive response gets dulled. And we have to retrain it. And retraining it, it's almost a religion, because you have to practice it daily, consistently. I even tell some patients to set reminders on their phone every hour just to do a kettlebell squat in their mind, right? Just to find that position again, to sort of resettle that. So you sort of asked me how we get into it and diagnose it. So I'm observing, I'm looking for these things. If we want to be formal about it, we can go through the Bateman criteria, which is basically looking for patterns, stereotyped hypermobility. So can you bend your thumb back to your wrist? Does your elbow hyperextend more than 10 degrees? Can you bend over? There's a lot of things we can look at to formally diagnose it and give someone the diagnosis of EDS. But and these criteria, they're always being modified. And the current issue is that if you have a connective tissue disorder, then you don't qualify for an EDS diagnosis. Which, just to get into the nitty-gritty, if you have rheumatoid arthritis or if you have lupus or something like that, then it disqualifies you from EDS, which seems a little bit silly, because it's not really related to hypermobility. But separate from that, we're looking, is it global hypermobility? And then more focally, are there specific joints that have been overused and stretched? Because you can have hypermobility in a specific joint from a stretch injury, like an ankle sprain.
Right.
So is this a more global process? Is it a focal process, or is it some combination of the two?
Right. Okay. Thank you.
We're opening a can of worms here, and I'm sorry.
Yes. So I do want to say, in regards to EDS, for the diagnosis, I know that patients, and what the research is showing is going to a geneticist for the confirmed diagnosis, correct?
Well,
Right.
but the geneticists go through the same process.
Right.
There's no gene testing.
Right. So there is no gene testing for HEDS, but for the other forms of EDS.
So if you want to rule out other things, you may
Right.
be able to.
Right.
But for the ones that we most care about for what we're treating,
HEDS.
we can do these same things if we want to take the time to do them. But the utility, I don't find there being much utility other than patients having some diagnosis that they can hold on to, like fibromyalgia, right? Like how many patients 10, 20 years ago were so happy to get a diagnosis of fibromyalgia because it finally explained everything that they had going on, except that it doesn't really explain anything.
Right.
It's just a cluster of symptoms, right? And it doesn't correlate with any treatment. Well, fibromyalgia, actually, there's some things that can be helpful there. But for EDS, having a formal EDS versus a hypermobility spectrum disorder, there's no difference. The treatment approach is no different at all. So what's the utility here other than giving some peace of mind, if it does do that at all?
Okay.
It's a placebo, I think.
Okay. Any questions? Anyone virtual, you can either put a question in the chat or if you want to ask. Yeah. Go ahead. We have a question here in office.
What is the difference between cold laser therapy and this machine?
Okay, so cold laser therapy uses laser technology, and this uses radio frequency. So you won't feel, well, you're going to feel warmth with this when we're doing it for pain relief, versus cold laser, I don't think you would be feeling warmth at all. Yeah, it's a different modality. It may be, the use of it might be aimed to treat the same things, but this is a different method because it is radio frequency.
So is one more effective than the other? Yeah.
I haven't used personally cold laser for my patients. I've found Takar therapy to be the most effective and the most diverse in treating many musculoskeletal lymphatic things. So I'm biased because I prefer using this. Go ahead. Yeah.
What about tear in a muscle? Does it help with that?
Yeah, so if there is any fibrotic tissue after a tear, it can definitely help with that. There's different settings and protocols that we use if there's scar tissue present as well. But one of the great things, because this does cause a diathermic effect, is it promotes circulation in the area. And so if there is a tear and you want to be promoting circulation, it's going to do that. Final question.
In terms of pelvic floor,
yes.
Does it also deal with incontinence?
Right. So this is a good question. So the question was, for pelvic floor, how can you use Takar therapy for urinary incontinence? And the answer is that we can use different electrodes directed towards the bladder. We can also use internally and directed towards the anterior wall of the vaginal wall, targeting the bladder from that direction as well. It depends. But if you're wanting to use it to facilitate uptraining or strengthening of the pelvic floor, I have used it in patients who have just like their muscles are tight, and we use it first to release the muscle tension and then promote circulation in the areas. Then it's easier for them to get a full contraction in their pelvic floor. So we can use it that way as well. There's many avenues to try to use it for incontinence. Question in the back.
So I remember you saying in the presentation that it's if there's like different structures might feel more heat. What about like the scar tissue that help the scar tissue with that? Would you feel more in scar tissue? And I feel like someone's gonna ask this question, but I want to ask it, I guess. But if also someone has like cellulite, would that potentially help with cellulite as well?
Okay, so 2 questions were asked. The first one was, with Winback Takar therapy, when you're using it over scar tissue, do you feel increased heat in that area? And the answer is yes. And then the second question was, can you use it for cellulite for more cosmetic purposes? And the answer is yes also. You would most likely use the mixed setting. and different intensities for that. Okay, questions. Okay. Are there any negative side effects to the patient and or practitioner with the bracelet radiotherapy? Are there any negative side effects? Not that I know of. I can tell you that Takar therapy is also safe to use with patients who have had joint replacements. So that's another pro of using this versus other modalities. But using the bracelet specifically, Kevin?
The biggest thing, hopefully you guys can hear me, would be sometimes if you're working at a relatively high intensity with the bracelet on, you're going to get, increased vascularization in that part of your forearm through your hand. So the only thing we've seen is sometimes people will feel a little heavier in that arm just because we've brought, more blood to the area. What we recommend, we've done studies, there's no long-term risk to using it. In fact, it's actually shown to help any of our manual therapists with, arthritis and things like that they suffer from just by wearing them during their treatments. The only thing we recommend is washing your hands with cold water if you've been using them for a longer period of time to bring the temperature back down in your hands. It's more for a comfort thing than anything else.
So Kevin was saying this has been researched. This is FDA approved, and the Johns Hopkins Pelvic Floor Program is really pioneering the use of it. And so they have many protocols for different pelvic floor physical therapy specific uses. And this technology has been used in Europe for many, many more years than in the United States, specifically for pelvic floor physical therapy as well. But what Kevin was saying was that with the bracelet, when you're using it as a physical therapist, our hands do warm up. And so sometimes you just made me remember this, that sometimes during treatment, I actually will take a break because my finger or fingers are quite warm. So you want to, and see, this Kylie's stealing the Takar therapy to use it, which is totally fine. So yes, I hope that answers that question. Are there any questions? And let me know if that did answer your question. Are there any other questions virtually for any of the providers, or let me just see. Okay. I don't see another G-chat. Not G-chat. I don't see another chat question, but there's another question here.
I just want to know how would any help you do the lymphatic system? Because I know the lymphatic system is very important. So I'm just curious how that helps with that.
The question in office is, how does Takar therapy help with the lymphatic system? And I can only speak to the lower extremity use that I use it for. And what we did is we used a setting that would actually go back and forth between different resistive and capacitative settings for the Takar therapy, and that just promoted the lymphatic flow. My patient noticed decreased swelling in her lower extremity afterwards. That's as much as I know. Kevin, if you want to chime in.
Yeah, and we have a few different protocols in place from the lymphatic and drainage standpoint. It also is something with the various attachments you can use with other things such as compression therapy. So we see it combined a lot with compression boots, especially where you can, set both electrodes and someone go through their compression therapy at the same time. So just kind of helping stimulate in two different ways in the same process.
Okay. Sorry, I just went into the wrong thing. Let me stop this. And then I'm just looking for any more questions virtually. Or no? You asked your questions before. Anything else you want to add? No.
There's a lot you could talk about, right?
Go on.
Oh, question here. No questions, but thanks for an informative session. You are welcome. Okay, so if there are no further questions, we're going to wrap up. I'm just going to finish with just showing some closing slides. Okay. Let me make sure that I'm in the right. You guys are getting a close-up of my face. Okay, I'm going to stop this video and share my screen to finish up. Just make sure I can do this. Okay. Wait. Here we are. Okay. Is that showing up for you all virtually? Can you see the PowerPoint again? Can someone just chat me? Yes. Okay, great. Thank you. Okay. All right. So this is just some references. Let's see, can I turn this back on? I'm just going to show you guys here some references, Q&A expert panel. So this is some contact. Oops. Okay, contact information. Let's turn it back on. If you have any question.
I shouldn't have walked in the room.
What happened? I'm going to stop this. Okay, we're going to try that again. I don't know what happened. Take two. One more time. Okay, contact information. So if you have any questions, feel free to call us, email us. I listed here our Facebook, YouTube, and Instagram. I want to also mention our podcast, which Dr. Sieferman was featured on, and we spoke at length about physiatry and the different treatments that they offer at Manhattan Pain Medicine. So if you want more information about that and you want to hear a more in-depth conversation, it is on there. I also want to point out that we had a video go viral, one of the podcast recordings. And this video was actually, or this podcast episode was Sex After 70. So, yes, listen to that podcast because there's a lot of information and there's a lot of people out there, obviously, who want to know that information too. But there's a variety of different topics that I cover with different experts in the fields, in different fields and different specialties. So please check that out on YouTube and wherever you stream your podcasts. Thank you so much for joining. It is September still, and September is Pain Awareness Month, as I mentioned. That's why we're having this event. So we are having a special where the Win Back to Car Therapy is at a discount. We normally have it added as an add-on service for about $45. But this month it's $20. So if you're wanting to experience it here at Inspira, please come on down. So it is an add-on, but we also do it for wellness. So you could come for wellness fitness. If you're not coming for physical therapy, for example, we have athletes who call sometimes who just want to have Jakar therapy to their calves or plantar fascia for wellness purposes. We can do that as well. Okay, thank you all so much for joining us. Dr. Jason Sieferman, thank you so much for being here. If you have any questions, feel free to reach out to us. Everyone have a good night.